Welcome to PGOG, postgraduate class in obstetrics and gynecology, and today's topic is diagnosis of endometriosis. Now, just to revise, we have already seen in the last class on pathophysiology and classifications of endometriosis. There are mainly two types. One is a pelvic endometriosis and other is extra pelvic endometriosis. Pelvic endometriosis is much more common. And what we should understand even to diagnose the endometriosis is these three variants of pelvic endometriosis, that is peritoneal disease, ovarian, which is called as endometrioma, and deep infiltrating endometriosis. In the extrapelvic, intestinal endometriosis is the most common extrapelvic type of endometriosis. It can involve bladder or ureter. It can be seen on the under surface of the diaphragm, especially on the right side, and this is explained by the movement of the peritoneal fluid clockwise fashion in the peritoneal cavity. So along with retrograde menstruation, this current of the peritoneal fluid movement also explains the presence of this right-sided diaphragmatic under surface of the diaphragm endometriotic lesions. There can be pulmonary endometriosis, umbilical, and scar endometriosis, as we do encounter in our career. A few cases of scar endometriosis, especially cesarean section scar, and rarely episiotomy scar endometriosis is also seen. In the peritoneal disease of the pelvic endometriosis type, first is a peritoneal disease. So here there is a superficial peritoneal disease or endometriotic lesions are present. And whenever there is these endometric lesions are present, they do ooze blood during the menstruation and irritate the surrounding structures. There is increased inflammatory response also. And ultimately there is a formation of adhesions. So it leads to adhesion formation and distortion of anatomy, so that tubo-ovarian relationship is disturbed or tubal motility is disturbed. Even tubes are patent, but motility is disturbed because of the presence of peritubal adhesions, peri-ovarian adhesions is also is responsible for many mechanisms where infertility is the ultimate outcome of this endometriotic lesions. Whenever we say ovarian endometriosis, it is endometrium, which is a better terminology as compared to the chocolate cyst of the ovary. Third pelvic variant is deep infiltrating disease, which is the most challenging one to diagnose, where the depth of the invasion of the tissues is more than 5 millimeter, and it is usually this these nodularity is present. Nodules are present in the retroperitoneal space, and these nodules, if we do the histopathological examination, they do contain dense fibrous tissue as well as few strands of the smooth muscle tissue are also observed, and it is mainly it is a retroperitoneal disease. So these are the three variants: peritoneal, ovarian, and deep infiltrating endometriosis, DIE. So if I say endometrioma, then that means we are talking about the ovarian endometriosis. If I say DIE, that is deep infiltrating endometriosis, then we are talking about this third variant. And peritoneal is superficial, where the depth of invasion is less than 5 millimeters. There is, though we say that it is a presence of endometrium-like tissue outside the uterus is the definition of endometriosis, but there are certain differences between this ectopic endometrium and eutopic. Eutopic is the endometrium which is situated normally at the inner lining of the body of uterus, whereas anywhere else it is called as a ectopic endometrium. So it is an endometrium-like tissue. Why we say it is endometrium-like tissue is because of these three differences. First is there is more of estradiol in the endometriotic tissue. Content of estradiol is more as compared to the eutopic endometrium, and it is the reason is there is a defective aromatization of estradiol to estrone. So conversion of estradiol to estrone does take place in the eutopic endometrium, but this is getting affected or there is a defect in that, and that is why there is more of a estradiol saturation E2 level is more in the tissue, not necessarily in the blood, but in the endometriotic tissue itself, there is increased estradiol level as compared to the normally situated utopic endometrium. Prostaglandins are more, so the amount of prostaglandins which are secreted is more or present is more as compared to utopic, especially prostaglandin E2, and this triggers further inflammatory response so that endometriosis becomes a state of chronic inflammatory condition. There is increased progesterone resistance is important. The difference between the ectopic and utopic, and in patients of endometriosis, even utopic has increased progesterone resistance as compared to normal patients with no endometriosis. But increased progesterone resistance is much more in ectopic tissue as compared to the utopic tissue. So whenever we are giving a progestogens as treatment, we have to give it in a higher dose because of this fact that this ectopic endometrium has a relatively resistance to the progesterone, because the progesterone receptors are less in number in the ectopic endometrium as compared to the utopic endometrium. What is the mechanism of generation of pain in patients of endometriosis? It is because of the focal menstrual blood irritating the surrounding tissues. As every menstrual cycle during menstruation, the menstrual blood is getting secreted even by the ectopic endometrial cells also, and that irritates the surrounding tissue, leading to the pain. Adhesion formation and collection of menstrual blood from ectopic endometrium in the closed spaces, that also leads to the onset of pain. Endometriosis is a chronic inflammatory condition, so that there are increased inflammatory cytokines in peritoneal fluid, and these are generating pain. And there is, whenever there is a deep infiltrating disease, especially, there is irritation or direct invasion of the pelvic nerves in a deep infiltrating type of pelvic endometriosis. Infertility and endometriosis, we say that they do go hand in hand. And so if general population endometriosis is seen in around 10%, prevalence is around 8 to 10%. In group of patients who have infertility, the incidence is as high as 30 to 50% in various studies. So there is an association between these two. So how it leads to infertility is there is a distorted pelvic anatomy because of the adhesions, which is affecting the ovum release from ovary as well as ovum capture by the fimria because of these adhesions. Decreased ovarian reserve is commonly seen in patients with endometriosis, and it is usually because of the previous ovarian surgery, such as this removal of endometrioma, or it can be because of the destruction of ovarian tissue by the endometrioma. There is a chronic inflammatory condition, and this inflammation affects the development of follicle. It affects fertilization as well as it hampers the fertilization, and it affects the implantation also. So at all these stages, there is a problem because of this inflammation, and that is how patients with endometriosis, even if they go for IVF, the response success rate of IVF is relatively less because of these problems with the implantation also. It is associated with anovulation, as follicle formation itself is affected by this inflammatory process. It is associated with corpus luteal insufficiency or luteal phase defect. There can be luteinized unruptured follicles, especially because of the peri-ovarian adhesions. And association of endometriosis and hyperprolactinemia is also seen by certain researchers. And whenever there is a hyperprolactinemia, that adds to the problem of anovulation. Endometrium itself is not receptive for implantation because there is an abnormal gene expression in the endometrium, and that prevents a successful implantation. So at many levels, this disease is playing the role. It's not only the problem of ovum pickup, but even the folliculogenesis, fertilization, implantation, corpus luteal insufficiency, luteinized unruptured follicle, associated hyperprolactinemia, and endometrium itself not being responsive for implantation because of the abnormal gene expression which is seen in patients of endometriosis. Now, whether endometriosis is responsible for recurrent pregnancy loss, the research has proven that there is no correlation found between these two, and it is not a cause of recurrent pregnancy loss. But as expected, because there are more pelvic adhesions, there is increased risk of ectopic pregnancy because of the hampered tubal motility in patients with endometriosis. Now, it is a disease which is associated with difficulty in diagnosis. And diagnostic challenges are there because there are no specific diagnosis signs and symptoms for this disease. Closed DDs need to be ruled out, especially pelvic inflammatory disease, irritable bowel syndrome do mimic it, and for many years patients are being treated for these conditions and the diagnosis of endometriosis is missed. Unfortunately, there are no diagnostic laboratory tests to diagnose endometriosis. Presentations are varied. That means patient to patient. Some patients might present with as a adnexal mass, others might present with severe dysmenorrhea or with deep infiltrating disease. Some patients might have only the difficulty in defecation or dyspareunia as the symptoms. So presentations are so different and they are many times treated for many years by non-gynecologists also. Now, even if we go for imaging modalities have false negatives in the sense that peritoneal disease is usually it is difficult to catch it even by MRI. Ultrasonography it is very difficult as well as with MRI also. Peritoneal lesions are sometimes many a times missed. So there are many false negatives with imaging modalities also. And overall it is seen that in the hands of good gynecologists and centers also delay in diagnosis from onset of the disease to the diagnosis, the duration it's considered to be as long as 8 to 10 years. That means patient remains undiagnosed and untreated for these many years, even if she has endometriosis. When should we consider endometriosis? We should consider, especially the pelvic endometriosis, we should consider whenever there is a dysmenorrhea, which is triple. Triple is the pain starts before menses, it is present throughout the menstruation, and it lingers even after the cessation of menstruation. That is why it is called as triple here. Triple dysmenorrhea in patients with endometriosis. Dysmenorrhea is new in onset. It is not present since menarche, but if it has appeared since last few months or years, and it is progressive. It is becoming bad with the duration of the or with the passage of the time. And if it is a severe dysmenorrhea, all these features are suggestive of endometriosis, and it is the presenting feature in 80%. In some patients, the disease remains asymptomatic. But if you are asked which is the commonest symptom, your answer will be dysmenorrhea, which is triple, new in onset, progressive, and might be severe also. This deep dyspareunia, which is new in onset, again it is a feature, common feature, and non-menstrual pelvic pain is also seen NMPP in 70% of the patients having this endometriosis. So it is not always dysmenorrhea, it is sometimes non-menstrual pelvic pain. Intermenstrual pain is also seen in many patients as high as 70%. Infertility can be the patient comes as a case of infertility, and then you evaluate the patient and then you suspect that she has endometriosis. And if patient has a ovarian mass or adnexal mass, then we should suspect or we should have a high level of suspicion and rule out whether she has a endometriosis. All these features might be cyclical or non-cyclical. Not necessary that always there will be a cyclical presentation or symptoms will be there. Use of symptom diary, questionnaire or apps. This is the latest recommendation by guideline, ISHRI guideline 2022, that is European Society of Human Reproduction. and embryology, that is ISHRI 2022. This is the society which is giving guidelines, and they are reviewing the guidelines and again redefining the uh, guidelines very frequently. And 2022 is the latest guideline which says that there is a possibility that if you ask the patient to keep a symptom diary, or you use a questionnaire, or you use an app, then possibility of detection of the endometriosis, diagnosis of the endometriosis increases. There is a possibility that it might increase. Less typical presentations are dysuria, dysphagia, that is the painful defecation, painful micturition is dysuria, painful rectal bleeding or hematuria, shoulder tip pain, which is because of the right-sided diaphragmatic endometriosis, catamenial pneumothorax. Catamenial is a terminology used for whenever there is any symptom associated or around the time of menstruation. So catamenial pneumothorax, cyclical curve hemoptysis, chest pain if there is involvement of pleura or lungs with the endometriotic lesions. Their patient might present as a case of heavy menstrual bleeding, postcoital bleeding, which is rare, and it is because of the presence of endometriotic nodules in the vagina. If there is a scar endometriosis, there will be history of cyclical scar, swelling, and pain around the time of menstruation or just before the menstruation. Chronic fatigue is also a common presenting symptom. There are so many times there is a cluster of GI symptoms, gastrointestinal symptoms such as abdominal pain, nausea, vomiting, bloating, distension of abdomen, early satiety. And that is the reason why I said that so many times patients are being treated by a non-gynecologist, and the irritable bowel syndrome is a close differential diagnosis along with pelvic inflammatory disease. So symptoms do not have any much help. Symptoms wise, we do not have any much help to diagnose the disease because there are so many symptoms which are common for other conditions also. When we examine the patient per abdominally, presence of pelvic mass is more common in endometrioma, and that is why per abdominal palpation of the mass is not common. Usually the endometrioma also remains as a pelvic mass, which is palpable on per vaginal examination and not by per abdominal. Per speculum, rarely we can get blue or red vaginal nodules. On per vaginal examination, pouch of Douglas tender nodularity, especially on the uterosacral ligaments, which is appreciated at 4 and 8 o'clock of the cervical base. If it is present, this tender nodularity on the uterosacral ligaments, it is highly specific for endometriosis. Fixed retroversion of the uterus might be there because of the adhesions. There can be adnexal mass on one side or masses on both the sides, which are tender, fixed, and irregular because of the presence of endometrioma. But normal examination does not rule out the diagnosis. And overall, this examination or signs have low diagnostic accuracy. Now, even if on examination there are no signs, the clinician, whenever is suspecting endometriosis, should proceed with the investigations. And the first investigation is ultrasonography. In a patient who is sexually active, one can proceed with transvaginal, or one can do even transrectal ultrasonography. It can detect ovarian endometrioma. It is very useful. Ultrasonography is useful for detection of endometrioma. How it is seen is, it is seen as a cystic structure with diffuse low-level internal echoes surrounded by a crisp echogenic capsule. So this low-level internal echoes is also described as classically as a ground glass appearance of the cyst, and that is highly suggestive of ovarian endometrioma. There might be presence of septations, 1 to 4 loculi might be seen, but there are no solid areas or granulations as opposed to the ovarian cancer. And these findings are highly specific, and they do suggest highly specific is there is a positive predictive value is very good as far as ultrasonography goes for the diagnosis of ovarian endometrioma. There is no role of CT scan or HSG to diagnose endometriosis. MRI helps in diagnosing mainly ovarian endometrioma, and it is better than ultrasonography in differentiating between a fresh bleeding in a cyst, ovarian cyst, and a chronic collection of blood as seen in endometrioma. So that way MRI sometimes helps to differentiate between the, because bleeding might occur even in a functional ovarian cyst or in a benign ovarian tumor also, such as cystoadenoma. So how to differentiate in these cases is, in these cases, MRI might be better to differentiate between these conditions and endometriosis. MRI can detect deep infiltrating endometriosis as presence of nodules. So this the imaging modalities do help in diagnosis of DIE, that is deep infiltrating endometriosis. So sonography and MRI, they are reliable to diagnose ovarian endometrioma, less reliable, but still they can detect deep infiltrating endometriosis as nodularity in many cases. But unfortunately, these diagnostic modalities do not help us to detect peritoneal disease. Now, for a few years, there was an excitement about use of CA-125 to diagnose endometriosis. CA-125 is a glycoprotein secreted by coelomic epithelium. It is raised even during menstruation and in pregnancy. So, normal women also, there can be an increase in CA-125 level. It is raised in non-mucinous ovarian, epithelial ovarian cancers. It is also raised in endometriosis, acute PID, or leiomyoma. So whenever there is a peritoneal irritation, whatever condition leads to the peritoneal irritation, it can lead to the rise in say CA125. So there is no role, it has no role as a screening test or for diagnosis of endometriosis because it has low sensitivity as well as specificity. But in a diagnosed patient of endometriosis, if there are persistent high levels after surgical treatment, that usually indicates a poor prognosis. So that much of the value is there for C125, that there is a diagnosed patient and we have done a surgically treated, and then if we do CA125 and it shows persistent high level, that indicate a poor prognosis for the patient. But diagnostic value is not there, and that is why if you are asked whether CA125 is a diagnostic test for diagnosis of endometriosis, your answer should be no. Now, this is something new, a recent advance as far as endometriosis goes, where it has been given that there are microRNA particles are released. These aberrant microRNAs are released from endometriotic lesions into the blood circulation, and these are measurable, which these can be measured. They can be measured in serum or blood. They are also found in certain cancers. Cancer cells also produce these abnormal or aberrant forms of microRNAs, which are specific for that cancer. Similarly, for endometriosis also, specific microRNAs, abnormal microRNAs are detected in the circulation, which is specific for endometriosis. Measurement of these microRNAs may present a novel, non-invasive diagnostic test for early detection and intervention of endometriosis, and it is currently under development. So if you are asked what are the recent advances as far as this topic of endometriosis goes, your answer should be this. This is the new addition, that microRNA measurement in the blood or serum, which will help in near future for in the early diagnosis as well as early interventions in patients of endometriosis. Now, this is the most important slide according to me as far as diagnosis of endometriosis goes, that there is a major shift in the recent guideline. If you read the guidelines few years back and you read the latest guideline, as I said, 2022 is the latest guideline. There is a major change in the diagnostic approach in suspected cases of endometriosis. Previously, it was said that laparoscopy is the gold standard, and whenever you are suspecting endometriosis, you must go ahead with laparoscopy. But now there is a change. Equal weightage is given even to the line of management where you go for imaging and use of empirical hormonal therapy rather than going for laparoscopy in a suspected case of endometriosis. So you should discuss with the patient, and as per patient's preference as well as her presentation, severity of symptoms, and possibility of various differential diagnosis, all these factors are to be taken consideration, but there is a equal weightage is given to this approach, imaging plus use of empirical hormone therapy, where we can use estrogen progesterone combination or only progesterone can be given on the basis of clinical diagnosis. Whenever we suspect clinical diagnosis, we have two options, and we should discuss with the patient either to go ahead with imaging and even whatever is the imaging result, positive, negative, to use empirically hormonal treatment, especially estrogen progesterone combination or only progestrogens can be given. Or one can go ahead with laparoscopy depending on what severity of symptoms patient has and what she wants as a further management. It helps in diagnosis as black powder burn lesions are said to be typical, or atypical red or white lesions can be seen. And from these lesions, if we can prove the disease by taking a biopsy, it helps. But negative histopathology does not exclude the disease, is the most important component. This is the most important part, because so many times when we take biopsy, the report comes as negative. Histopathology report might come as negative. That doesn't mean the disease is not present. And in the same sitting, we can go ahead with the surgical management. These are the advantages of laparoscopy. But laparoscopy is no more considered as a gold standard for diagnosis, especially because deep infiltrating endometriosis might be completely missed by laparoscopy. In the diagnostic approach, so whenever we suspect endometriosis, we have two options, either to go ahead with the empirical treatment and do the imaging, or go ahead with laparoscopy. We can try NSAIDs and we can try hormones. If there is no response, again we have two options. Discuss with the patient, discuss the side effects also of the drugs and cost of the drugs, and we can go for GnRH analogs such as GnRH agonist, antagonist, or we can that at that stage we can proceed with the laparoscopy. Laparoscopy should be avoided when patient is on or patient has taken within 3 months, previous 3 months, if patient has taken hormonal treatment. Thorough inspection of peritoneal and pelvic cavity should be done, and probing should also be done, especially to see for the diagnosed deep infiltrating disease. Black lesions are said to be typical, gunshot or powder burn. Blue or red lesions can also be there, or white scarred lesions or vesicles are also seen. There is a high intra and inter-observer variability as far as this diagnosis of endometriosis by laparoscopy goes. But still one should do the RASRM staging. We have already seen this staging in the last class. It should be done along with Enzian score if there is a suspicion, Enzian classification if there is a suspicion of deep infiltrating endometriosis, and always one should go ahead with the endometriosis fertility index whenever a patient is keen for conception. In every patient of infertility with endometriosis, whenever a surgeon is operating, one has to do this RASRM staging. For deep infiltrating endometriosis, Enzian classification is mandatory, and if patient is keen for on conception and has infertility, EFI, endometriosis fertility index, documentation is also mandatory. Biopsy to be taken from suspicious areas, but most important is DIE, deep infiltrating endometriosis, might be completely missed by laparoscopy. About the histopathological diagnosis, histopathological diagnosis examination is indicated in endometrioma whenever it is more than 4 centimeters, because there is a rare risk of endometrioid or clear cell ovarian cancer, And that is the reason if there is a persistence of endometrioma of more than 4 centimeters, it is an indication for surgery and histopathological examination. Similarly, whenever there is a deep infiltrating endometriosis, say the endometriosis over the rectum or over the bladder, then also this histopathological examination is indicated to rule out malignancy. Any two of three features are sufficient to diagnose endometriosis: presence of endometrial glands, presence of stroma, and third is hemosiderin-laden macrophages. But negative histopathological examination does not exclude the disease. Because there is a formation of adhesions and fibrosis, and even in endometrioma, so many times there is a long-standing endometrioma, there is so much of flattening of the this surrounding epithelium that the diagnosis any two of these three features might not be seen in spite of patient having the disease. So this last sentence is important. Negative histopathology does not exclude the disease. So why it is a diagnostic challenge, the disease as a endometriosis, why it has a diagnostic challenge? Whenever we suspect endometriosis, first thing is physical examination, which has a poor diagnostic value. If we get positive tender nodularity over uterosacral ligaments, or we get adnexal mass, or rarely we can see the vaginal nodules, blue colored vaginal nodules, then it's okay. Otherwise, in majority of the patients, there are no findings present on physical examination. CA-125, as we have already seen it, CA-125 has no diagnostic value. Ultrasonography, MRI, they do help for the diagnosis of endometrioma or deep infiltrating disease, but peritoneal diseases might be completely missed, and that is the reason why negative findings do not rule out disease. Normal USG, normal MRI is not sufficient to say that patient is not having endometriosis. So next is laparoscopy. Laparoscopy helps in best in for the diagnosis of peritoneal disease and endometrioma, but we might miss deep infiltrating endometriosis. And last is histopathological examination. As we have already just now we have seen, negative histopathological examination do not rule out the disease. Thank you. Next class we'll see treatment of endometriosis.